Good afternoon, everyone. Thank you for joining us here today. My name is Megan Williams, and I'm the Director of Support Services at Alzheimer Group. If you're joining us for the first time, Alzheimer Group is an organization who supports people living with dementia and their families. We offer a range of programs and services, including an in-person day program for the person living with dementia, counseling and support groups for caregivers, and education workshops. Today's lecture is being made possible by the generous support of the Lindsay Memorial Foundation and the Lasner Learning Center. Today's lecture, I'd like to introduce Dr. Michael Hennes, who will be discussing dementias after brain injury. Dr. Michael Hennes is a doctor of chiropractic medicine and a board-certified chiropractic neurologist at the Neural Connections. He received his doctorate in chiropractic from Northwestern Health Sciences University, graduating with both his doctorate and bachelor's in human biology. Dr. Hennes currently holds a diploma in neurology from the American Chiropractic Neurology Board. He has special interest in neurological rehabilitation, neurochemistry, and nutrition, and working in traumatic brain injury, concussions, vestibular disorders, and migraine disorders. So we will, that's a handful. As most of you know, at the end of the lecture, you can use the chat function and ask any questions you want, and hopefully we will have time for some questions. So without further ado, Dr. Hennessy, this is your time.
All right. I'm hoping everybody can hear me because I can't see you. So yeah, today we're talking about dementias after a brain injury, which is a super fun topic because neither one of those things is super awesome, but I get excited about both of them. So specifically, we're talking about how to maintain the gap between dementia and brain injury, or how to prevent a brain injury from leading to dementia. Now, the research is out on whether or not there's a direct cause, but that's what we're talking about it. And we're talking about it because the public, everyone's getting smarter about brain injuries, traumatic or acquired, and people want to be healthy. They want to keep their health as good as they can, as long as they can. And you want to enjoy your golden years. One of the biggest risk factors for dementia is growing older. Well, you want to enjoy those later years rather than having this golden handcuff, if you will. You're getting older and you've got time to spend with friends and family and doing the things you like, but you can't because your brain's not working so hot. So that's what we're talking about. That's why we're talking about it. And I'm here because they invited me to be here, and I love this stuff. Okay, so who am I? We got the professional stuff out of the way, so we don't need to focus on that. I'm a chiropractic physician. I'm a functional neurologist. I work down in the Minneapolis area. Beyond that, I'm a father, I'm a husband, I'm an athlete, and I'm just a normal guy. So I get really excited about this stuff. And so if you need me to slow down or anything like that, bounce your fingers up and down on your keyboard or your chat, ask a question, something like that, and just tell me to slow down, and I'll do that. If we have questions, we'll try and get to them at the end. Thankfully, I can't see them because otherwise I get really distracted and we don't get anything done. Okay, but enough about me. Let's start talking about brains here. Okay, so here's what we're talking about. It's a little tiny gooey mass about the size of your two fists put together, weighs about 3 or 4 pounds. It's got the consistency of Jell-O, and it floats in a fluid because it would actually crush itself under its own weight if it wasn't suspended. Okay, that makes it pretty fragile. It actually doesn't take much to move it around or distort it. So in my practice, we see concussion and brain injury in people that think they weren't really that injured because they had a 5-mile-an-hour car accident or something along those lines. But it's still enough to make that brain move around in the skull. Okay, but today we're talking about dementia. Probably common knowledge, but I got to cover some bases here. So what is dementia? Dementia is the loss of cognitive function, thinking, remembering, reasoning, to an extent that it interferes with your life. Okay, that's the key point in the medical world, is if it's not interfering with your life, you're not going to get diagnosed with dementia, which can be a problem because we can see some of this stuff early on, and if we do something about it, there might be something we can do earlier until things actually get formally diagnosed. But there's more to it than that. Dementia has a bad rap of being a memory-only problem, and that is not the case, okay? Dementia is confusion. It's having difficulty speaking, understanding, or expressing your thoughts, reading and writing. Um, you can wander around, get lost in a familiar neighborhood, you're repeating questions, or you're having trouble with new words or unfamiliar words, or even having hallucinations because parts of your brain are confabulating memories that maybe aren't there, or you're just getting stuff confused that way. Okay. It's also poor decision making. You're acting impulsively. Think gambling. Maybe you were never a gambler, but that's starting to come up. That can be something we look at as maybe a flag. Acting impulsively, making bad decisions, handling money irresponsibly, forgetting to pay bills, that sort of stuff. Emotional liability. That means your emotions aren't predictable. You don't care about other people's feelings. Maybe you have inappropriate emotions. A lot of this stuff overlaps with other neurological disorders, but it is common to the dementia world as well. Okay. Losing interest in normal daily activities. I think I said not caring about other people's feelings, all of those things. There's also a movement component to dementia where it can take longer to complete daily tasks. You're losing balance. You just don't trust what you're doing. Something simple like this, getting up on a step stool to grab something out of the top of the cabinet, or changing a light bulb, something like that. Simple everyday tasks can become difficult because you're moving slower or your coordination just isn't there anymore. So all of that stuff sounds terrible. It is. What do we want to happen, right? What's the goal? We want to stay mentally sharp. You want to carry your wit, your intellect, your wisdom into your older years here. And let's not make the mistake of thinking dementia is only an old person's disease, right? I have plenty of patients in their early 20s with concussions that have all kinds of brain fog, which is mild cognitive impairment, okay? It's all on a spectrum, okay? You want to make good decisions about your life, your finances, your actions, the people around you. They want this for you too. You want to be confident in yourself, right? You want to be able to trust your feelings, trust your emotions, your impressions, make sure they're appropriate and reflect who you really are and who you've developed yourself to be as a person. You want all of these things to be consistent with how people know you. You don't want to be throwing anybody any curveballs or anything like that. You want to be able to trust your body. You want to be able to move confidently, right? If you can't move confidently, chances are you're going to become a homebody because it's too dangerous for you to step out. You're afraid of rolling your ankle or something like that. Okay? All of this plays into it, right? But most of all, you want to know that there's a plan. You want to know that you're in control and you're not at the mercy of the fates. And before we talk about that, we have to understand some basics about the brain. This isn't going to be a medical school lecture on neurology, but I am going to get a little bit deep in some of this stuff. So again, if you have questions, let me know. I've already been told to slow down. Whoops. All right, I'll try. All right. So we're not concerned with the lobes of the brain in particular, or the different parts of the brain and what they do. Rather, when we're talking dementia, we are concerned about some of the smaller supporting pieces or the building blocks of the brain. Um, by looking at the bigger parts of the brain and where damage is occurring, we can usually figure out what kind of symptoms someone's having. Or vice versa, by looking at the symptoms someone's having, we can figure out which part of the brain is involved. And that becomes very important when we start looking at doing some rehabilitation or trying to incorporate some interventions. But for now, we're going to go real deep, real quick, looking at the little itty bitty parts of the brain. Okay. Basically like looking at the brain under a microscope here. So we're looking at some of the smallest little vessels of the brain. Everybody knows you have capillaries in your skin, in your organs, everywhere around. You also have them in your brain. And a capillary is the link between arteries, which carry oxygen-rich blood, and veins. And we're looking at the little tiny vessels that actually aren't pictured on here, but the little tiny vessels that carry blood flow between, and that's where we do all of our oxygen exchange. Okay, we'll get into some of this a little bit later, but we're looking at that. We're looking at these green little cells encapsulating these blood vessels, forming what's called the blood-brain barrier. Think of that like an impenetrable barrier between your brain's blood supply and the fluid that the brain is floating in. Okay, it keeps your brain cells protected from the outside world. It's really hard to get stuff across that barrier. So when we're looking at things like medications or supplements or that sort of stuff, it can be difficult to get things into the brain. Okay, so a medication that might work for inflammation in the rest of the body doesn't necessarily work in the brain because we can't get it there. Okay. One of the other things we can look at is if suddenly something that is not supposed to have an effect on the brain is, then we know that barrier is leaking, and that can be very therapeutic for us to know as well. So looking at this, we've got these purple cells are actually neurons or individual brain cells. And then we have the green ones, which are immune cells. They're actually made up of glial cells, and they help form what's called the glial lymphatic system. They do a lot more than that, but that's what I'm going to focus on today. And that is essentially the garbage system of the brain. But there's a catch. It only seems to work when we sleep and when we move. So our cells, neurons included, as they go throughout the day and they go through about their normal processes, they create waste products, and we have to get rid of those things, right? They eat some sugar, they break it down, there's waste products associated with that. We don't want those to build up, and it's the glial lymphatic system or the lymphatic system in the brain that helps get rid of those. And if you don't sleep, it can't quite do its job, so that stuff starts to build up and can cause some inflammation. Again, we'll get into that a little bit later. And then the other thing that I'm really going to draw attention to is a couple of proteins. When we're talking about dementias and Alzheimer's, we're concerned with two main proteins. Let me back up a little bit. A protein is like a building block. Think Legos. One Lego on its own really doesn't tell you what's going on. If you put 1,000 Legos together, all of a sudden you have a house or a castle or a spaceship, really whatever your imagination can come up with. I liked Legos as a kid, can you tell? But as these proteins or these Legos are developing, when you start putting those bricks together, they have to have a pattern. And what we find in dementias is that pattern starts to break down. So specifically, tau proteins, which we look at intently in Alzheimer's disease, they help form these microtubules. Think of it like a big hose and wire and scaffolding system that help hold your cells together. They give them shape and they help move things along the cell. Okay. When that microtubule structure starts to break down, we get deposits of tau, and then they can't do their job very well anymore. The other one we look at is alpha-synuclein. We look at this more in Lewy body dementia, and these are used in cell signaling. Okay, so the parts of the cell right out towards the end here where they talk to one another, that system breaks down in that process. So if we continue on, how do we actually diagnose dementia? Okay, diagnosis can involve many different avenues. It's usually a primary care provider, an MD, a physician's assistant, a nurse practitioner, or a neurologist. Now, I'm a chiropractic neurologist, so normally patients are coming to me and they've not gotten a diagnosis yet. And if that's something we're suspecting, I have to actually send out for it. That's not a diagnosis I'm making on my own. Or they already have a diagnosis and they weren't really given a whole lot of options. It was just a wait and see what happens. And that's never a great place to be, is just to be told to wait and see. And so we see if we can give them some strategies. We're not necessarily curing, but we're giving strategies. So that's an overview of how the brain works and the major things we're looking at in dementia, and then how we actually diagnose it. Some tools we use, we can look at, there's some new blood tests that are coming out that can be fantastic. I've got some functional ones that aren't exactly mainstream. We can look at, is that blood-brain barrier breaking down? Is your immune system paying attention to some of these different proteins? And that can be very useful, especially if if you're a younger patient and you've got a family history of this stuff that runs in your family, and you want to know how diligent you have to be with your health to keep this stuff from happening, it's kind of a weird paradigm for me to think, well, if I'm not at risk, I don't have to take care of myself. But that's kind of the mentality. So sometimes we run this test and say, look, you've got some risk factors for this. Now's the best time to look at that, because it's going to be a lot easier now in your 20s and 30s than it is in your 50s, 60s, and 70s to deal with some of this stuff, right? Because we're learning life habits at that stage in life, as opposed to trying to break them when we're older. Psychiatric evaluations are huge in this. Looking at scans, genetic testing. Just because you have genes for something doesn't mean we have to turn them on, but it also means that we really have to pay attention so those genes aren't turning on. And then there's the good old-fashioned bedside neurological exam, just to see where the brain is at. I'm going to bounce back to brain scans. And one of the issues that I run into with patients is they say, well, my MRI was clean, my vascular scan of my brain was clean, we don't see anything on it. Well, the problem with scans, and it's getting better with resolution as the MRI magnets get bigger and that sort of thing, but what we're finding is you need about 50 to 70% change or damage per se in order to see this stuff on scans. So if we wait for the scan to be positive to do something, wait until you have a diagnosis rather than just symptoms, we're pretty far progressed along, and that's not a great place to be. So I tend to err on the early side. Everybody that comes into my office gets a cognitive screen. I actually run a Montreal cognitive assessment. It's a really, really basic one, but it's really quick, and you'd be surprised how many highly functioning people have some variety of cognitive impairment. And I look at that, I measure it, and I work on it on everybody that comes into my office, even if that's not their complaint, because it takes me all of about 3 minutes to do. 5 minutes to do. All right, let's get into how this stuff breaks down. Okay, so central nervous system injuries, CNS injuries, they alter immune responses. Now, we don't know exactly what's causing dementia, what's causing Alzheimer's. I'm just going to say dementia because it's all one spectrum here. But we have some factors that we know play into it. Okay. One of the things that plays into it is how well your immune system is working and your inflammatory responses. Okay. In the realm of brain injuries, we know one of the biggest problems, especially for lasting neurological symptoms after a brain injury, is prolonged inflammation. So those glial cells we talked about earlier, the green little booger looking things on the screen, they get turned on, and if we can't get them to turn off, it's not quite that simple, it's not on or off, but if they're not regulated appropriately, they start to go a little bit wild and do things that we don't want them to. They're not predictable anymore. And when we see that, we get a myriad of things that we don't want to happen. So our blood vessels start to leak a little bit, and that blood-brain barrier, the blood-brain barrier starts to break down. We can see lower immune cell counts. We can see lower regulation of the smart parts of our immune system. We can see leaking in all of our immune barriers, our stomach, our lung, our brain, our sinuses, and we can get easier infections. Okay, this also triggers more inflammation, which brings us right back to the top of the cycle, and it all repeats. Okay. So more infections, think chronic post-concussion patients, people that had a head injury long ago, and they've just never quite been the same since. They seem to get sicker and sicker and sicker. And we see that a lot, okay? This just is a picture description of what was on the last slide. So we have the brain, we have an injury, we have immunomodulators because the immune system needs to turn on after a brain injury. We need to get rid of any damaged cells. We need to increase blood flow to the brain. All of these things are immune mediated, but there are some negative side effects as well. So we can actually end up with our immune system being dampened, making the way for opportunistic infections to happen, thereby increasing inflammation, and again, repeating that whole cycle over and over and over again, okay? So how does this work? Normally, when we have an injury, we have some kind of inflammation or an infection or something like that. That information is perceived by the brain. The brain then goes down and dampens the immune responses to some degree, and we have an inflammatory response. but the brain dampens it, and we have this state of homeostasis or balance in the body. Okay, that's what we want to happen. When we have, I'm sorry, this is what normally happens when you're not sick. Somehow we have some kind of inflammation that overpowers the brain, and the brain isn't working so well, or we're not able to compensate very appropriately, and we end up in a state of shock or where the immune system is working overtime. In the aspect of a brain injury, we don't necessarily have to have any kind of inflammation, but we get a skew in the opposite direction here, where the brain actually inhibits the immune system. And that is called CNS injury-induced immunodepression, the CIDS. And again, with our immune system dampened, we're no longer able to fight off, say, normal life infections. You get colds more often, you get the flu, you get all of these opportunistic things, leading to more inflammation, and again, just repeating that inflammatory cycle, okay? Now, I don't want to say inflammation is a bad thing. We have to have it. That's how our immune system communicates with the rest of the body and the brain. We read those chemical messengers. It's when we have too many of them, or we stay inflamed when there's no longer a problem, that it becomes a problem. All right, so trauma and inflammation, they can actually alter mitochondrial function here. So the mitochondria I didn't talk about, but they're these little, potato-shaped organelles or little tiny organs within your individual cells, and they're responsible for creating the energy for the cells, okay? When we have an injury, those cells start to work in overtime. We get all sorts of, there's all kinds of numbers and a pathway through here, but you get all sorts of calcium that comes into the cell. Calcium is an ion, it's an electrolyte, and that makes the cell work in overtime, and it essentially overloads the mitochondria. So now the mitochondria become damaged and they can't produce the amount of energy that your brain needs. In a brain injury in particular, one of the things we see is this cascade of too much activation. Your brain works overtime because of the initial injury, especially. And that results in an energy deficit, partially because of the calcium coming in. The calcium then ends up causing problems in the mitochondria where you can't create enough energy to heal appropriately, and the neurons become weaker and weaker and weaker because they're not able to do their job. They're not able to signal, and we can start to get some brain fog or mild cognitive impairment. As that progresses and the neurons aren't working as well, that can progress to neurodegeneration as the inflammation stays and the neurons just don't work appropriately. They can't signal. If they can't signal, your normal processes break down. You can't sleep. Your lymphatic system can't drain. So all of this stuff is related. Okay, I keep saying it's a never-ending cycle, and it keeps being a never-ending cycle. Okay, microvascular changes after an injury, same sort of process. After an injury, we have all sorts of, we have an injury and we have a neurotransmitter released that allows calcium into the cells. Okay, and that leads to too much activation, and we start to get inflammatory mediators, this arachidonic acid, where the mitochondria can't keep up, so they're releasing basically inflammatory messengers, cytokines, things that our immune system uses to communicate, but now we have too many of them, so we have an excitotoxicity. Okay, and the brain is being activated too much. As all of that happens and we have all of this inflammation floating around in the brain, we can actually start to see, I'm sorry, you can't actually see my mouse, the microvascular damage. So those capillaries we talked about earlier, they start to become damaged, they start to calcify, and now you aren't getting nutrient transfer from inside the blood to the brain, and we just start to suffer more, okay? Last one on the nitty gritty, I promise. After brain injury, we also tend to see reactive oxygen species or free radicals. This was a big thing, early 2000s. Everyone was talking about free radicals and antioxidants and how good they were for you. And they are, especially in this particular scenario where all of these inflammatory signaling chemicals, as they're floating around, they cause this oxidative stress that leads to mitochondrial dysfunction, and it leads to cell death in a way that we don't want it. Okay, cells die. That's part of normal daily life. What we want, though, is we want them to go through a process called autophagy. not important. It just means that when the cell gets old, it knows it, and it kind of packs itself up from the inside out. When we have all of this damage, we can start to have cells that are actually damaged, and they die from external forces, and our immune system then has to go after them, and we get further neurodegeneration. We suspect that's one of the processes that's in play when we start to get protein misfolding. We get neurofibrillary tangles with tau, we get Lewy bodies, we get all of these proteins breaking down. Okay, all of those Legos we talked about earlier start to just get dumped in a pile and stuck together any which way, so that they don't make sense, and it doesn't work as well as it should anymore. Okay, so all of that sounds really terrible, and it's very melancholy, actually. And I don't mean to offend with any humor I try and throw in there. It's a heavy topic, so I'm trying to lighten it up a little bit, but that can be a little bit difficult. So how do we fix it? What can we do about it? And the question I always get asked is, can I prevent dementia? And the official answer in the research is no, not yet. But we've identified some risk factors that seem to help out. So what can we do? Most of this stuff is pretty common sense. If you have high blood pressure, you need to fix it. If you have high blood sugar, you need to fix that. If your blood sugar is too low, you have to fix it. Maintain a healthy weight, right? You can read all of those things as well as I can. Basically, you need to take care of yourself, because your brain is more sensitive than most of the other cells in your body. So if you can live your life in a way that you're taking care of your brain, your body will more or less follow suit, okay? I've got a study, and I didn't link it in here. There's something called a Bredesen protocol. Dr. Dale Bredesen wrote in 2014 that I go through pretty much with all of my patients, and that's where most of this slide got pulled from. That works with it, and it's factors to reverse cognitive decline. Earlier stages, it works fantastic. Once we actually start to have protein misfolding and some breakdown of those proteins, it becomes much more difficult. And the best we can do is hope to slow it down at that point. But because we're talking about brain injury and what we can do about it, I start this stuff right away. Okay. So let's talk brain injury and dementia here specifically. The brain, it contains more neurons than there are stars in the known galaxy. And each one of those neurons makes hundreds of thousands of connections with other neurons. So it's almost impossible to count, and we just have to estimate how many connections are actually within the brain. And the connections are where our strength in our neurological processes is, okay? So if we have 10 neurons and each one of those neurons talks to one another, that is an exponential amount of connection. And connection is where we get our memories. It's where we get our thought processes. It's where we get our motor learning. So the connections are really what we need to preserve. When we have protein misfolding, some of those connections start to get disrupted. Even if we were to remove all of that misfolding, the connections are still gone. And that's why we can't cure dementia and Alzheimer's, because we can't ever get that pattern of connection back the way it was, okay? But like I said, we have to go through and work on some of these things. Otherwise, we are basically just paving the way after an injury for things to break down. Now, that's not to say the research would suggest one singular brain injury is not enough to cause dementia or Alzheimer's or chronic traumatic encephalopathy, which I didn't talk about a whole lot in here. But also seems to be a tauopathy. So that tau protein, that Lego in tau, is very heavily involved in CTE as well. But repetitive traumas, so this is why we look at American football so intently, because those guys don't necessarily get a concussion every time they go out and play, which is debatable. I shouldn't have probably said that on video, but that's debatable. Anyway, it's the small repetitive impacts that they have over and over and over that we find tend to be more damning in their cognitive breakdown. Okay, it's the constant introduction of inflammatory or insulting injuries to the brain that seems to have more of an issue. After a brain injury, after a singular brain injury, as long as your brain heals, we don't seem to see that as much. Now, if you have a brain injury, in my world, I work mostly with concussions. If you have a concussion that doesn't heal and you constantly have symptoms, which means you constantly have inflammation, that's when we start to see more of this cognitive decline start to develop. And that is then a risk factor for dementias developing later in life. Okay. Just because the brain is super complicated does not, however, mean that treating the brain or working on the brain has to be super complicated. Okay. The brain basically only needs three things to survive. Okay. It needs fuel, it needs oxygen, and it needs to be activated appropriately. Okay. If you can give the brain those three things, then it will largely be healthy. So we have to expand on this a little bit. So for example, fuel is all of the nutrition, all of the chemistry that goes into using that nutrition, and all of the waste created by all of those processes. So maybe we should call it metabolism. But if any of those things breaks down, the whole system needs to start compensating so that you can use your oxygen, so that we can activate those neurons. Okay. Furthermore, the nutrition and all of those processes need to be in place before you need them. Otherwise, it also starts to break down. Think of it like putting gas in your car. If you go to leave on a road trip, but your tank is empty, you're not going to get very far, right? You don't fill up for a road trip after you've taken the trip. It has to be there in advance. Otherwise, you're compensating in some way, shape, or form, okay? When we're looking at oxygen, we're looking at red blood cell health. We're looking at inflammation, iron, B vitamins, all of the things that can impact how well you're carrying oxygen. We look at breathing mechanics. Do you snore at night? Do you have sleep apnea? You probably aren't breathing that great throughout the day either. Do you know how to use your core to breathe? Do you use your diaphragm? Or are you an obligate chest breather? All of those things are very important. Again, looking at how well the brain can function, or is it struggling to do its job already? And then you add a brain injury on top of it is a recipe for things to go wrong, okay? And then activation. Are the appropriate areas of the brain communicating the way they should, okay? And this is an avenue that we take in the office all the time. I do neurological rehabilitation with patients. That's what my practice is based around. I look at nutrition and is it there to support how well the brain works? I look at breathing mechanics to figure out how well the brain works. Is my rehab going to be appropriate? Okay. So what sorts of things can we do to improve all of this inflammation, improve neurological signaling? Okay. Vagus nerve stimulation is fantastic. Some of this stuff you have to be in my office or someone's office to do because we have all the cool toys. Yes, that's me, and yes, I have myself hooked up to all of it. This is great to do on a wellness basis as well. Okay. So what do we have going on here? I have a laser disclosure. I am a speaker for Erconia lasers. We use Erconia lasers in our office. We would use them whether I was a speaker for them or not. My business partner and I are both speakers for Erconia, but we had the lasers before we became speakers, so we like them that much. They're the ones that have done all the research, they hold all the patents, and they work very, very well. So we use low-level lasers on a frequency of 10 hertz. That is a vagal frequency. The vagus nerve is part of the central nervous system, and it dampens things like inflammation. It wanders from our brainstem all over through our body, and it controls things like our heart rate, our digestion. There's immune links to it, all of that stuff. So it's very important. So how do we stimulate that vagus nerve? Okay, stuff you can do at home: breathing, meditation, yoga, humming, singing, yelling, gargling, moderate intensity exercise, cold exposure, whether that's cold air in the morning if you live in areas where it is cold, tough to come by this time of year. Otherwise, short cold shower. Doesn't need to be freezing cold water. Okay, just turn the water down a little bit. 30 seconds is really all you need. There's no need to hurt yourself in the cold water and make yourself that uncomfortable. If you look back across history, we look at people that have lower inflammation and great vagus tone. We look at monks that chant or praying or drum circles in different cultures. All of these things have vagus nerve stimulation aspects to them, and we've kind of gotten away from that in today's society. Some things you necessarily can't do at home. Obviously, the laser, it's very cost prohibitive to have one of these in your home. I have some clips on my ear. We're doing transcutaneous vagus nerve stimulation. So this tragus of your ear and the inner part of your ear actually has a link to the vagus nerve, so we can stimulate that. You can also apply vagus nerve stimulation on the neck where it runs down from the brainstem, and you can actually get to it there. So we can do electric stimulation with it there. One of the biggest objections I get is I don't like electric nerve stimulation. I don't like being electrocuted. This is a little bit different than muscle stimulation. You don't actually feel the current involved. So the most uncomfortable part about these ear clips is actually the clip. It's like a little clip-on earring you use with little kids, but they can start to pinch a little bit after about 10 minutes. But as far as the electricity goes, you really don't feel anything at all, okay? What else can you do at home that stimulates the vagus nerve? Moving stimulates vagus nerve, and exercise is great for that. We talked about moderate intensity. That means getting out, walking, jogging, basic movement. Hula hoop would be great, jumping rope. It doesn't need to be heavy weights, although heavy weights has a way of activating the brain that is a little bit different, that is very neuroprotective as well. But it doesn't need to be high impact. If we're talking about older patients, sometimes osteoporosis is a factor, and we can't necessarily load those things. Again, heavy weights actually have been shown to increase bone density, so that's something that we should always consider. But specifically talking vagus nerve, we're talking moderate intensity exercise. So what does that mean? That means as you're doing some kind of aerobic exercise to get your heart rate up, you should be able to carry on a conversation, but you should struggle with that conversation just a little bit. Okay, so you need to get that heart rate moderately elevated, and that's different per person. If you haven't worked out in 20 years, getting your heart rate just a little bit higher is probably going to do that for you. If you are a triathlete, probably going to be easier for you to carry on that conversation. So we need to work a little bit harder, okay? But being able to talk to the person on the treadmill next to you, again, it doesn't have to be running, but treadmills are good examples. If you're talking to the person on the treadmill next to you and you aren't able to have a conversation like we are now, that means you're probably working out just hard enough, okay? Movement also helps us move around that cerebral spinal fluid. Remember before I talked about the brain being bathed in this fluid. We need to help move that fluid around so that we can get all of the gunk out of our brain and help the nutrients move around that brain as well, okay? The way we do that is by actually these upper spinal segments moving around and basically creating a pumping action. The more we move, the more we have to use our spine and our core stabilizers, and just giving all of that good information up to the brain and then helping all of that stuff move around through, okay? Likewise, there's very little substitute for sleeping well in today's society, and I am guilty of this as well. There is not enough time in a day, and so we tend to sacrifice our sleeping time to stay awake and get things done and drink coffee. This is actually water now. I've had my cup for the day, so I'm good. But we substitute with things like stimulants, and by not sleeping, we lose the neuroprotective effects of sleeping. We don't take out the trash in our brain. We don't regenerate neurons appropriately. We don't solidify the memories that we gained throughout the day, and it just makes it harder for our brain to function. So what do we do with patients when they first come into the office? Everyone leaves here with a meditative breathing exercise, and we harp on them about sleep. And if they're not sleeping well, we ask them about it until they either lie to us and tell us they're sleeping great and getting their good times and they don't need the alarm clock anymore, or they actually do it. We never know which, but we go until they tell us that they're sleeping well again, okay? When we have patients come back to us a couple years later, the question usually is, how are you sleeping? Are you still sleeping good? You know, I stopped going through that routine a couple months ago, and then my symptoms started again, and it kind of clicks in their head that sleep picked up on that again. So really complex stuff here. We've got to move, we've got to sleep, we've got to do something that's almost meditative, and good food, keeping yourself hydrated. All of this stuff is very, very important. And it's easy to say that these are the basics, but the basics can be very complicated sometimes, especially in the world of processed foods and fast food and our high-paced lives, okay? So what do we look at with food? This is specifically a picture of a Mediterranean diet. I like it. I like Mediterranean food, so it's easy for me. But the general rule with food is eat good food, not too much, and eat mostly plants. Okay, that doesn't mean you need to have a plant-based diet, but plants should be a good portion of what you're eating. Okay, it's easy to go into eating meats, especially the way we raise them now, get them to market quick and they taste very good and all of that stuff. But there are many, many biologically protective things in plants that we really should be consuming on a regular basis. Eating not too much brings us to the topic of fasting. Everyone's favorite topic is fasting, because everyone always says, well, I need to starve myself, and that's not the case. Fasting has all sorts of neuroprotective benefits in that it activates the immune system to essentially go after our weaker cells, which we want. We don't want weak cells holding us back, whether it's in our brain, in our muscles, in our digestive tract, any of that stuff. Okay, so I go about fasting 2 different ways depending on my patients. Okay. Women, we find, don't do well with intermittent fasting. Okay, if we start pushing to 16, 18 hours fasting, or even a week long where we're consuming like 400 calories a day, which has been shown to be very good, we find in women that we push them to actually an inflammatory cascade, and we can start to cause gallbladder issues. So in women, I tend to do what's called a fasting mimicking diet. And that means every night you're looking for a 12 to 13 hour window where you're not eating anything. So what does this mean? If you eat dinner at 6 p.m., that means you eat breakfast at 7 a.m. Okay. If you're getting your full 8 hours of sleep or more, that window, you're asleep for most of it. So you really don't feel that hungry. Okay. Men, on the other hand, seem to be able to handle intermittent fasting for longer periods better, 16, 18 hours. And you don't need to do this every single day, but throwing some kind of fast into your eating routine has been shown to be very neuroprotective. It also seems to help with reversing, to some degree, autoimmune disease. It has implications in allergies, autoimmune diseases, all of those things, all things we see in the office. Largely because they're related to brain injuries, but there's all sorts of components that are neuroprotective when we're talking cognitive impairment or dementia as well. Okay, so if we don't evaluate and we don't start treating appropriately, where does this stuff end up? Well, we know where it ends up. It can end up in neurodegeneration. Okay, we see neurodegeneration, we see inflammatory issues, we can start to see autoimmune diseases pop up because we have those leaky barriers we talked about earlier. Pain tends to just be worse because we're inflamed. Migraine disorders, all of these things can develop if we're not evaluating and treating the things that we find. Just because we don't have a diagnosis doesn't mean your symptoms aren't real, and doesn't mean that we shouldn't go after them. Okay, so as of today, if you have some cognitive impairment or you have some symptoms that don't quite make sense, but you're having trouble getting a diagnosis, we really only have 2 options. Everyone always thinks if they do nothing, things will just continue on the way they are and will maintain the status quo. And we find that's not the case. If you do nothing, we tend to decline as time goes on. Things start to break down even more. Or you can do some things to make improvements. Obviously, the sooner you start that, it would have been better to do in your 20s, but the best time to start something was a long time ago. The second best time is today, because you know about it. Okay, the further down the path you go, the harder it is to course correct. So course correct as soon as you know how or are able to do so. Okay, so what do we have to do? We have to figure out what's missing, and there's always some piece of the puzzle that's missing. In our office, we always hear, well, I've done that already. And one of the things I like to tell patients is, you've done all of the right things. You've listened to your doctors, you've gotten the tests, you've been proactive, but you're still not any better. And most of the time it's because people have done the right things, but they've done them at the wrong time or at the wrong intensity, or they weren't doing enough things together at once. Okay, you really can't separate out all of these different avenues when we're talking about healing the brain or making improvements in the brain, right? Again, if there's damage, we can't necessarily reverse it, but slowing it down, or depending on the stages, maybe having some reversal. Okay, so I'm going to throw a case study in there. Chelsea was a patient of mine years ago, and I still keep in touch with her. And she did not actually have dementia, but she did have cognitive impairment to the point where she wasn't really functioning. She was really kind of a recluse where she just wouldn't leave the house. She was 40 years old. She had one son, and her symptoms really started right after that. But she had POTS, which is postural orthostatic tachycardia syndrome, where she would get dizzy upon standing. Basically, what that means is her brain wasn't sending blood flow to itself when she stood up or moved around. And she had all sorts of supporting symptoms with that. Okay, anxiety I find largely is a consequence of anemia or not having appropriate oxygen delivery. Okay, so what do? We did an exam. We did some labs, and we found some stuff that wasn't working well in her brain. Her eyes weren't moving appropriately. She didn't know where she was in space. Okay, and then on her labs, she was anemic, she was inflamed, and she was insulin resistant. All things that we discussed as being risk factors for dementia. Okay, what we did for her is the nutritional management stuff was actually pretty easy. We taught her how to manage her blood sugar. We put her on intermittent fasting. I gave her some supplements to slow down her blood sugar metabolism so it wouldn't spike and drop throughout the day. She was iron deficient because her stomach acid wasn't working real well, so she wasn't pulling iron out of her food. And that's a consequence of decreased vagus nerve tone, all stuff that we've talked about already. And then we gave her a myriad of neurological exercises, largely working on eye movements to work on some stuff that way. And she's doing great. The last time I saw her, she said, "So I didn't realize it, but I was up on the countertop cleaning my cabinets, standing there without a ladder or her husband there to catch her if she fell, and she didn't even think about it." So hers was more of a movement issue, but she really had some hallmarks that leave her open to developing some cognitive impairment as time went on. Okay, so we look at this in everybody that comes into the office because it is just that important. Okay, that was a lot of information and kind of a whirlwind, but I had a lot to share. So, do we have any questions that came up?
It looks like we don't have any questions. Thank you so much, Doctor.
Yeah.
It's kind of scary because, probably so many people have had concussions and they don't really know that they've had concussions or they've had some type of trauma to their brain.
Yeah.
I have a question. So, say, for example, someone falls. I mean, I'm not sure necessarily what age I'm speaking about, but if someone falls, like, what should someone do to make sure that they're well looked after to maybe prevent, whether it is someone who, as you said, in their 40s, or maybe you slipped on the ice, because we have lots of ice in Montreal, in their 60s. Do you need to necessarily hit your head to have some type of a concussion and go for it?
Sure, that's a great question. I'm glad you asked because I normally harp on this, but this wasn't a concussion lecture, so I didn't.
Yeah.
You do not have to hit your head to have a brain injury or a concussion. Okay, any impact to your body in which there's significant force can cause a brain injury. Again, because that brain is floating, it can really bounce around in that bony skull. So that really slow car accident where maybe your airbags didn't go off and you didn't hit anything, but you still jolted forwards against your seatbelt. And if it locked you in place, we see brain fog with stuff like that all of the time. And it can be difficult to distinguish that from, say, a whiplash injury, which can cause very similar symptoms. I usually argue if you've got a whiplash, you probably have a concussion. And if you have a concussion, you probably have a whiplash. And so you have to look at both of them. As far as what you should do, one of the things that I'm really trying to do in my community is pushing for a screening. Okay, we're really good around here about working a concussion screen into high school athletes. What's your baseline so that you can return to play afterwards? But we're really bad about it in the rest of the world. Okay, so for those 4 years where we have you in high school, you probably had a physical in your middle school years. So 6th grade, you have to get one every 3 years. So maybe you have 3 baselines throughout your athletic career in high school. I think colleges are pretty good about it now too. But if you're not an athlete or you're just out working your job because you're an adult, when's the last time you had a yearly physical that also looked at your brain to figure out, maybe your eyes don't move that well to the right, and you get a little bit dizzy with that. That's not great, but we know that. If we don't know that and you have a brain injury, and all of a sudden I'm seeing this and I'm trying to rehab this thing that's just normal for you, we're never going to get there, and it can be very frustrating for you and me alike. So first of all, if you have the resources and the ability to do it, find a provider that is versed in brain injury and looking at doing some kind of screening. It doesn't have to be a yearly thing, but to have some kind of baseline in the last 3 years or so would be fantastic. Getting regular blood work so that you can track your trends and see where stuff is breaking down, okay? I check my own lab work quarterly. I like to do about every 6 months to quarterly on my patients, depending on what's going on. At a minimum, every 6 months, okay? Most people will do it yearly. I would argue that that's probably not enough to catch stuff going on, especially with different seasons. You get sick in the spring because you have allergies, and then the allergies go away in the summer, but midsummer it's super hot, so maybe you're dehydrated and you don't know it. In the fall, allergies start to come back, and then in the winter we have viral loads from everybody being indoors. There's always something to be working on and fine-tuning. And the last part is really to just be honest with yourself. Is not to say, well, I hit my head, so this is normal. And it's really easy to go down a slippery slope with that. Because everyone thinks, again, I talked about this, if I do nothing, it will improve or it'll at least stay the same. But when the changes are very gradual, it's hard to tell that we're declining. If you have friends that you see maybe, I don't know, once a month, once every 2 months, they might notice something different because their last impression of you was that you were doing well, you weren't doing so well, now you're not doing so great. They might catch it, but you in your daily life can have a hard time saying, well, I don't remember ever getting headaches because the headache started small and it grew and it got bigger and bigger and bigger. Now you just have a daily headache, but it's always been that way.
Yeah.
But it wasn't that way 6 weeks ago and you didn't realize it. So I encourage people to journal and keep track of how they're doing. It's very meditative and neuroprotective in itself, just for dealing with anxieties, which play into this quite a bit. But it also serves as a way to track symptoms that are maybe growing, but you maybe wouldn't recognize on their own. Okay. And don't be afraid to ask for help. If you hit your head, and a lot of times what I'll do with patients is I'll do an exam and I'll say, okay, I'm going to give you some basic stuff to do at home, aerobic exercise, breathing exercises, and we'll start with that, for example, and maybe an anti-inflammatory diet. And I'll say, come back in a month and see what's changed. And if things still aren't getting better, then we'll do some rehab. Maybe it's 2 weeks, maybe it's a month. If their symptoms get worse, they come back sooner. But asking for help sooner than later is always the best scenario, because we can get after it before compensation patterns really develop.
Absolutely. So don't ignore it. That's
yeah, exactly. Don't ignore it. Yep.
I do have a question. What about the effects of antidepressants? Does that cause problems in the brain?
So antidepressants are very interesting, and I just talked about this last week somewhere else. And the theory behind antidepressants is that we have an imbalance in our neurotransmitters. The problem is those levels are very rarely ever tested, and we don't necessarily have standards. So I don't know of a disease that's a deficiency of Xanax, but it sure seems to work pretty well for treating anxiety, although it tends to be a little bit of a tranquilizer. Same with SSRIs, or selective serotonin reuptake inhibitors. It lets that neurotransmitter hang out in your brain longer, so it has more of an effect. But a lot of these things end up being trial and error, okay? Increasing the time serotonin has to work can be very effective, but it might also accentuate the problem, okay? So they are very good in the short term when we need to have these things, right? It's just like taking an Advil or ibuprofen or a Tylenol or a steroid. They let us get through the pain and do our rehab, but we should still be working on them. Okay, the goal should be to get off of that medication. Now, that's not always the case, and I'm not naive enough to think that we can get everybody off of every medication. But the fewer we're on, the better. The less we're changing our brain chemistry artificially, the better. Okay, I realize that's kind of a beat around the bush answer, but fix that. We can start to get plastic change where we can actually get used to the amount of neurotransmitter from an antidepressant, which comes with its own challenges. As we get used to it and we compensate for it, it becomes harder and harder to undo that. And when we start working with things like dopamine or serotonin, those are working on movement centers of the brain. And so one of the major side effects with that is movement disorders, which are a whole other ball of wax and just as fun as anything else. So I'm not a huge fan, but I'm also realistic enough to know that they're needed. So kind of playing both sides of the coin on that one, I suppose.
Yeah, as you should. And then the last question I have for today is, do you see the benefits with exercise and meditation, I guess?
Absolutely. So exercise has all kinds of different benefits. So if we look at just moving in general, that's all kinds of information coming up to the brain. It's all kinds of activation in the brain, forcing you to know where your body is in space and just signal. Okay. It also has a big component of the brain sending information out. So working on those neurological connections. Okay. The more you move, the better you learn, the stronger your brain connections are, and the more we have to work with. So it's harder for our brain to decline. Okay. And meditation is very activating for the vagus nerve. And we also find, so one of the exercises I said I give all of my patients is a breathing meditative exercise. I don't usually tell them it's meditation. We Americans tend to think meditation's a weird thing. So I just tell my patients to do breathing exercises. I don't tell them it's meditation. But what we find is after 8 to 12 weeks is that we've actually increased the cortical thickness, or the gray area of the brain, the part of the brain where all the connections happen, which is very neuroprotective. So having people meditate 3 times a day before I have them do the neural exercises basically warms the brain up in order to do the rehab better. It increases oxygenation. It increases vagus tone so that we're having anti-inflammatory effects. We're working on our digestion. We're modulating our immune system. All the things that we know contribute to minimizing risk factors for all of this breakdown. So yes, absolutely, meditation and exercise.
Okay, thank you so much, Dr. Hennes. I feel like, as much as it's a hard topic, I feel like, the reality is, get everything checked out, try to eat healthy, exercise, and do what you can to I guess, enrich and feed and fuel that brain to prevent any further damage and dementias and cognitive impairment going forward. So
absolutely.
I appreciate your time, and we look forward to hearing from you hopefully soon. And as I said, everyone will be able to get this recording, and we will stay tuned and we see your slides. So thank you so much.
Absolutely.
All right. Take care. Have a great day.
You as well. Thanks for having me.
Bye-bye.